turnout. So just to give you a little background about myself, I am a pediatric neurosurgeon who has just a strong passion for neurotrauma and traumatic brain injury, spinal cord injury, all of these types of injuries. And one of the things that I really enjoy doing is sort of sharing my passion with a diverse group of people. Because as a neurosurgeon, I would be the first to say that in taking care of someone with traumatic brain injury, you need a neurosurgeon in the front, initially with the injury. But if I am the only practitioner that patient has, that patient is going to be in real trouble. And we'll talk about sort of the different types of things that these patients need as their injury evolves. If at any point I say something that is not clear, if at any point you have any questions at all, please feel free to just give me your questions. I have nothing to disclose. Haven't sold out to the big companies yet. I will say that this is the big reason why I'm here in California today. Is my new nephew, Rehab. So just as a trigger warning for anyone, it's pretty hard to talk about traumatic brain injury without talking about trauma to the brain. Kind of makes sense. So some of the things that we're going to see, intraoperative photos, I am going to show you pictures of the brain. If you are taking care of the brain, you should definitely see what it is that you're taking care of. I think the brain is fascinating. Some people are a little bit disturbed by it, so please let us know. And feel free to walk out at any time if I show you anything that really kind of gets under your skin. I am going to show some radiographic scans of serious brain injuries. I am not going to show any on-scene photos, so nothing like that. This is the metaphor that I think of personally when I think of traumatic brain injury, is this, I just love this photo, this train just kind of crossing over this bridge, and it just sets up, and like you see this, fierce river running underneath, and it just sets up this whole dynamic just tension. And is the train going to make it across? And that is how I view every one of my patients that I see. So over here, this train is leaving the land, it's leaving dry land. This is the point of the injury. This is where, the kid is driving and he doesn't really see a stop sign, and then a Ford F-350 just clocks him, driver's side, and bam, go, it's time. Now you're crossing the rapids. This is maybe the point where I see the patient and I maybe decide, am I going to do brain surgery on this patient or not? This is the point of the ICU stay. This is the point of the stay when he's out of the ICU and now he's back in the hospital, regular general neurosurgical floor. This is rehab. This is where he's getting physical therapy, occupational therapy, speech therapy. And then finally, as we're transitioning back to going back to school, before we get over here, to the other side, we have the time where we have strong rehab needs, so outpatient rehab needs. And we'll talk about sort of all of those things and how they impact the patient. Who cares? Why do I care about traumatic brain injury? Why bother? Well, especially in children, you're talking about 600,000 visits to the emergency room every year for traumatic brain injury. That's a huge number of visits. 10% of those visits end up with the child being hospitalized for their traumatic brain injury. 10% of those hospitalizations, for those kids who are hospitalized, will ultimately die from their injury, and then another 10% will have some sort of long-standing, long-term disability. So, I mean, compared to anything else that I treat, tumors in kids, cerebral palsy, all of these other things that I treat as a pediatric neurosurgeon, this guy takes the cake. Traumatic brain injury is sort of a crushing blow in the United States. Where do we need input for traumatic brain injury? Well, unlike other disease processes like cancer or we go back to cerebral palsy, there's just not a lot of research on traumatic brain injury. And there are, we do research, but there's still just a ton of unanswered questions. A lot of ways that we can make headway, and that's one of the reasons why I like traumatic brain injury so much, is because I really feel as though research done in it can really make an impact. So what do we need research on? We need research on diagnosing these injuries. So how do I find out if my patient that just got hit in the head or fell off a bed has an epidural hematoma that I need to evacuate? How can I do this faster? How can I do it even faster than that? These are things that we're working on. How do I get a patient from, let's say, near Joshua Tree to LA as quickly as possible? How do I decide of the 15 patients that may fall off of something and hit their head, which of those patients actually can be taken care of in a rural environment versus going to the city to, you know, CHLA or something like that? So that's another sort of thing that we need to figure out. Prognosis. When your child or your parent or somebody that you love has an injury, one of the first questions that you're going to ask somebody like me is, how is this going to impact my family member? I got to tell you, we don't have a lot of data for that, and so it's very hard to answer those questions. So we need research on that. Treatment, you know, as far as this, we need education on all levels. This is sort of the reason why I do talks like this, where I get a diverse group of individuals and kind of tell them about traumatic brain injury, so I can sort of spread the word about what we know, what we don't know, how all of us as practitioners can help these patients as much as possible. Development of rational neuroprotectants. Believe it or not, there is not a single pill that I can give patients to make their brain better after traumatic brain injury. I mean, if I said that about any other disease process, your jaw would drop. Okay? I mean, imagine if we didn't, if you got pneumonia and we just said, okay, well, you know, we'll put you on some oxygen and hope for the best. I mean, you know, in this day and age, you would not accept that as an answer, yet still for traumatic brain injury, there's no pill that can give. And then post-traumatic rehabilitation and neuroregeneration. So neuroprotectants are what can I give the patient to prevent injury. Neuro rehabilitation, prevention of neurodegeneration would be things, what can I give after the fact to get the patient back to where they were. Huh. There we go. Now, anatomy and traumatic brain injury. So I'm going to kind of fly through this. Hopefully nobody will fall asleep. And if you have any questions about anything that I'm talking about, please let me know. But it's hard to talk about traumatic brain injury without knowing about the anatomy of the brain. So Dr. Seuss wrote a book, Oh, the Places You'll Go. So I've kind of taken that title, Oh, the Spaces You'll Go. Okay? So blood can go into all of these different spaces. From an outside to inside view of the brain, the first thing you have is the scalp. Then you have the skull underneath the scalp. Then you have 3 layers of covering. You have the dura mater, which is like a thick, leathery covering. You have the arachnoid mater underneath the dura, which is a spider-like sort of connective tissue. And then right against the brain, you have something called the pia mater. And then finally, after all of these tissues, all of these different things protecting the brain, you have the brain itself. And we'll talk about where blood can go into all of these different spaces. And hopefully, when you get a patient where it says epidural hematoma, you're going to know exactly what that means. That means blood outside of the dura compressing against the brain. Scalp laceration. Why, as a neurosurgeon, do I even care about scalp lacerations? Let me tell you, in about the decade that I've been practicing, I have seen at least 1 human being die from a scalp laceration. That is totally preventable. So, scalp lacerations, you can bleed like stink, okay? This is somebody who's had a scalp laceration, and all of this is blood that is underneath that scalp, okay? I've seen more than a dozen patients who got blood products that they did not need, were set up for risk by a treatment that they did not need, had somebody just taken staples and stapled the scalp back together, or just whip stitch that scalp back together. So if you see a patient who's wearing, you know, like a turban in the emergency room, and they're bleeding into that turban, tell somebody, get that scalp closed, okay? It is vital, vital, vital that you do that. Skull fractures. This is sort of the, yeah, I told you, you had the trigger warning. So this isn't a baby. This is called a ping pong fracture, okay? This is what happens. Baby gets hit with like a softball or a golf ball or falls off of a bed. they can actually get a depressed fracture, and as pediatric neurosurgeons, you'll make an incision over here, and then you'll have to kind of pop that ping pong fracture back in. For tiny, tiny babies, it's totally possible. It's like popping a dent back in out of the car. Oftentimes we don't have to do that with those types of fractures, but occasionally if it's something where, you know, baby's got it right in the forehead, we'll go ahead and take care of it. A couple reasons why we treat skull fractures. So something you were telling me about a skull fracture. That's, wasn't it, you told me about the gentleman with the skull fracture where the brain was out of the skull fracture?
Well, not on the outside, he actually had...
But underneath the scalp.
Tissue coming into his eye socket.
Yep. Yeah. So that would be one that we probably would have treated. So reasons we would treat skull fractures, open skull fractures. These are fractures that are overlying a cut in the skin. If air can get into that wound, then bacteria can get into that wound, and it can set you up for a bad meningitis. Elevation of a depressed skull fracture, we already saw that. And then fixing what's called a dural rent or a cerebrospinal fluid leak. At some point, there are enough people in here that actually the information I'm about to give you may help a patient out. If you ever have a patient who had a traumatic brain injury and they're leaking fluid out of their nose, that patient needs to get seen in the hospital. Okay? So what that can be is it can be what's called CSF rhinorrhea, brain fluid that is going through a fracture, and then the brain fluid is actually leaking out of the nose. So that can present in a couple different ways. You can have clear fluid leaking out of the nose. You can have blood, kind of bloody tinged fluid leaking out of the nose. Or the other way that it can present is patients will actually complain of having kind of a weird taste in their mouth because it's leaking into their sort of the back of their throat, and they're sort of tasting that bloody type of fluid. Okay? So if you see that, that patient needs to get evaluated. So some of the things that we do for skull fracture, get a patient who has a depressed skull fracture, you'll make an incision over it, you'll elevate that bone, and then this is that leathery covering that I was telling you about. If there's a tear in that leathery covering, you stitch it up just like you would if you had torn fabric. Okay? Basilar skull fractures. This is another way that skull fractures can present. You can have patients who have almost like a black eye, or they have darkness behind their ears. The black eye is called raccoon's eyes, and that can be a basilar skull fracture up front. Or you can have a mastoid fracture back here, and you'll get what's called a battle sign. Okay? So if you see patients who are like that, one of the things that you check for, are you leaking fluid out of your nose? Are you leaking fluid out of your ear? That's another place where the cerebrospinal fluid can come out, is out of the ear. The majority of times when that happens, by the way, it heals itself, but those patients need to present for some sort of care just to make sure that they don't get a meningitis. So, we talked about the different layers before you get to the brain. You have the scalp, you have the skull, and then you have the dura. This is that leathery covering. If you get blood underneath that dura, it's called a subdural hematoma. If you get blood above that dura, it's called an epidural hematoma. And both of those can be surgical emergencies. The majority of the cases, they're not, but if you get enough blood up there pressing on the brain, then you need to get that blood out of there. So this is just a picture, this is obviously a pathological picture, of that dura, and then that's blood underneath the dura, and you can see it compressing against that brain. These patients can go on to have seizures, all kinds of bad things. This is what a subdural looks like on a CT scan. You can see that's the skull right there, and then the blood just kind of hovers around the convexity of the brain, and it can leak even between into the interhemispheric fissure between the two halves of the brain. Subarachnoid hemorrhage. This is blood that gets near the brain, and it actually gets underneath that arachnoid membrane, that sort of finger-like, very thin connective tissue that we talked about. So this is underneath the dura and actually underneath the arachnoid. It can just basically cover the brain. This is a pretty nasty subarachnoid hemorrhage. It's fairly common in traumatic brain injury that you'll get these types of injuries. It can mean that something worse is going on, like an arteriovenous malformation or an aneurysm. Aneurysmal subarachnoid hemorrhage is very different from traumatic subarachnoid hemorrhage, but both can go on to cause problems. It can go on to cause stroke. And this is sort of what a subarachnoid hemorrhage, you can see it's much more subtle than a subdural hematoma. Okay? You just have that little bit of subarachnoid hemorrhage maybe there and there. And actually that's a pretty nasty one. They can look even more subtle than that. This is the injury that you guys are probably going to see quite a bit. So this is something that would happen from blast injury, or it happens from a guy who maybe hits a tree too fast, airbag deployment. There's nothing, oftentimes there's nothing that you see on the CT scan in what's called diffuse axonal injury, but it's basically a rotational injury where the brain, the head has been rotated very quickly, and so the brain can actually hit both sides of the skull, and it can lead to very small micro shearing within the brain itself. So you can get a lot of these little punctate injuries that are all around the brain. You tend to get them in the deep nuclei. You can get them in the corpus callosum. They're not on the surface. They're inside the brain. And patients can present in a variety of different ways. Okay, you can see a patient with a totally normal head CT that is completely out of it, or you can see a patient who has these kind of speckled dots everywhere who, looks pretty normal, okay? So it's very variable in its presentation. It's variable in terms of its recovery. Fortunately, in children, a lot of these children get better. This is, if traumatic brain injury is a passion of mine, non-accidental trauma is a passion of my passion, okay? There's nothing worse than a preventable injury. And as a father of 3, I can tell you, non-accidental trauma or child abuse is just the absolute bane of my existence. So if there is one point in this lecture where I actually want you to pay attention, it's this right here. Okay, most common presentation for children, and this, even when you're outside of your practitioner position, like when you're in the grocery store, you can be on the lookout for these types of things. Most common history of non-accidental trauma is absolutely no history of trauma. Susie woke up and she started vomiting, and I brought her to the hospital, and you get a head CT and it looks like this. Or I left him at, his babysitter's, or mom's boyfriend is always a standard culprit of these types of injuries. Oftentimes these patients will present way after the fact. So frequently it will be shaking. Shaken baby syndrome is a pretty common presentation or common reason for these types of things. And that shaking will have started weeks ago. And so by the time they present to the hospital, because these are children who can't tell you they have a headache, right? By the time they present to the hospital, the disease process is well into its later stages. And so patients will actually present. They can have, this is kind of older blood because it doesn't look quite as dark. This is newer blood because it looks very bright. So very bright blood is new. This is kind of maybe a couple weeks old, what we call subacute blood. And then this is blood that's been there for a long, long time. Okay? Oftentimes patients will present with a history that's completely incongruent. Just doesn't make sense from the story. So, if a mom is holding a kid and the kid falls off the bed, we'll see in another couple of slides, that doesn't cause this, okay? So if that's the history, you need to put your antenna up, okay? This type of injury is caused from really, really bad trauma, okay? You can actually get, it's not just shaken baby syndrome. This could happen to you as an adult, but what it will require for this to happen for you as an adult is for you to get into the cage, like San Diego Zoo, with one of these 500-pound gorillas, and have the 500-pound gorilla shake you, okay? But the same thing, I mean, it's not like you're immune to this. It's just that as adults, there's nothing big enough to shake us like this, okay? Some of the risk factors for these types of injuries, young parents, inexperienced parents, although, again, patients and parents can completely violate these. These are just some of the predictors. Low socioeconomic class, single parents, and all of these things are just kind of stressors to the parents, and they don't handle the stress in a very good way. Prematurity of the child. So if the child has a lot of illnesses or is premature, you're more at risk for these types of incidences. And then drugs and alcohol. Please.
Sorry, I don't mean to.
No. I invited you to raise your hands and ask questions.
At the birth level, breech baby, forceps removed.
Oh, this is a fantastic question. Can they present like this? Absolutely. And we actually look for that, okay? Now, if you've got and I've had a really bad breach a couple of months ago where the kid presented with, huge epidural hematoma, huge subscalp laceration. I actually ended up needing blood transfusion because he lost so much blood underneath the scalp. But if you've got a kid who's like a year old and that's going on, it's not going to be from the breech. But definitely for your tiny, tiny babies, 1, 2, 3, even 4 months out, traumatic injury from childbirth, even vaginal delivery, where you're stuck in the canal for like 24 hours. Anybody who's nodding their head, I'm sorry for you. My wife went through that with her first, and it was like, it was traumatic for me, so I can't remember the baby. So non-accidental trauma, some of the things that we do when we suspect this, we get an ophthalmologic evaluation, so we get them seen by the eye doctors. You can actually see retinal hemorrhages in the back. Social services, 100%. Child protective services. What do you guys call it in California? Every state has a different name for it. Is it yeah. It was CPS in Georgia, but not in Ohio. We get an MRI of the brain. The MRI of the brain does a really good job, even better than the CAT scan, of sort of showing us the age of these different types of blood. We get an MRI of the cervical spine to look for other evidences of injury, and then a skeletal survey to make sure the baby doesn't have any injuries anywhere else. Sort of the suspicious constellation of the things that really push us to the point, because again, baby can't tell you, oh, it was the babysitter that did it. Retinal hemorrhages, subdural hematoma, like we already talked about, skull fractures, and skeletal injuries. So any baby that we even slightly suspected this, we put them through the ringer. So if you are walking your kid through Walmart and baby falls out of the cart and has a really bad fracture, don't be surprised if you take them to Children's Hospital if they do a workup like this, and don't be offended. You have to actually see a lot of false or true negatives to find those true positives. This is what retinal hemorrhages look like when you look into the back of baby's eyes. So, she fell off the couch onto the carpet. This is why this is garbage, okay? When you bring a kid in and they have an injury that looks like that, baby did not fall off the carpet. How do we know this? Okay, this is a fantastic study, okay? 203 documented incidences in this study. And this study was years and years back, in the 90s. These are documented incidences that happen in the hospital. How many people have seen the inside of a children's hospital? Like what those beds look like? Okay. The nurses who take care of these babies do not put baby in a crib way down here because they don't want to injure their back. So baby is way up in the air in these cribs. And if somebody accidentally leaves the crib, the side of the crib down, when baby falls onto the ground, it's from pretty high up. And I have never been to a hospital where the patient's room had carpeting, unless you're in like one of those really fancy, like, I'm a CEO of Standard Oil and I just got a quadruple bypass. But certainly not in a pediatric hospital. So baby is falling from a pretty high height onto hard floor. 203 documented incidences of this. We know exactly what happened to baby. of those 203 documented incidences, 29 superficial injuries. We're talking about like baby got a little bit of a cut, baby got a little bit of a bruise. Nothing else, okay?
Wow.
One linear non-displaced skull fracture, tiny little skull fracture. This is in more than 200 cases. And one fracture of the collarbone. That's it, okay? Babies are made out of cartilage, so they can drop from heights, and they bounce. Really dramatic, but it's not like, you know, your 80-year-old grandmother falling out of bed, you know, because, you know, grandma has osteoporosis and very brittle bones, and it's bad, bad, bad. But for babies, I mean, these are creatures that are low weight, and they can hit the ground pretty hard, and not anything bad happens, okay? So she fell off the couch onto the carpet is a garbage reason, okay? So just keep that in mind. Another place where you, as practitioners who are seeing these patients way after the fact, can be of great service to your patients is if you have a patient with a traumatic brain injury who is persistently complaining of neck pain, be suspicious, okay? Now this is a really bad injury, okay? This is an internal decapitation type injury, okay, where the head is literally off of the spine. Very subtle, but you can see that right there. That's where the skull interacts with the spine, and that's just a little bit too far off of the spine. But if you have a patient who had a traumatic brain injury, had a car wreck, and is complaining of just persistent neck pain, that patient needs to get evaluated, okay? Because, you know, I'll be the first to say it, we at the hospital will miss things. So what's the difference between a patient that I take back to the operating room and a patient I don't take back to the operating room? So your skull is a fixed space. It only has so much space to occupy the brain, the blood that goes to the brain, and the brain fluid. So if I throw something else in there, whether it be a brain tumor or a really bad bleed, that intracranial mass doesn't make that fixed space any bigger, okay? And what it will do is it will push onto the venous blood first, and also onto the CSF volume, the brain fluid volume. And it'll keep pushing, and it'll keep pushing until it gets big enough where it's pushing on the arterial blood, which means that you're not getting enough blood to your brain. And then finally, it will push on the brain itself. And if it pushes too hard on the brain itself, the brain goes down like this, and it herniates, and you're dead. So that is why we take these types of injuries so seriously. Blood pressure. Who cares about blood pressure in a situation like this? Your intracranial pressure is the pressure that your brain sort of exerts inside your skull. Your mean arterial pressure is the pressure that your heart is pumping up to your brain. I'm a keep it simple, stupid kind of guy, so I sort of think of these as two arrows pointing in direct opposition to each other, and I want to keep the blood pumping from the brain of a high enough pressure to perfuse this brain. So the two ways that I do that, I keep the pressure in the brain low, and I raise the pressure coming from the heart. It's kind of the standard. And that number, the blood pressure minus the pressure in the brain, is your cerebral perfusion pressure. The brain is a fascinating, fascinating organ. I'm in love with the brain. This is what millions of years of evolution have provided us. Your brain can function at wide ranges of blood pressure. So when you're sleeping, your blood pressure is way, way low, and your brain is still getting about the same amount of blood. When you're running, you're outside running that marathon, and you're really running, or you're in some national park and a bear is chasing you, your blood pressure is way up, and your brain is still getting about the same perfusion pressure. It's because the arteries that are going up to your brain, when you're sleeping and your blood pressure is way low, they open way up to allow all that blood in, and when you're running from the bear and your blood pressure is way high, they close down. So the thing to keep in mind is that after a traumatic brain injury like this, this regulation, this beautiful regulation, can be thrown off. So again, patient with traumatic brain injury complaining of severe headaches needs to get evaluated. Temperatures also matter greatly in traumatic brain injury. For every degree of temperature that I drop a patient, so from like 37 degrees centigrade down to 36 degrees centigrade, it's about 6 to 12% of metabolism of the brain. I can drop that down. And what we see is that when patients have a traumatic brain injury and they have fever, the pressures get way high because their metabolism jacks up. And if I can just drop that temperature down lower, I can actually spare the brain some of that metabolism. I can lower that, that pressure that's in that brain. From the time that the brain is injured and it is not getting blood, from the time that you have a stroke and the brain is not getting blood, anytime the brain is not getting blood and oxygen, you have 6 minutes. That's about the time that it takes for you to brew your coffee in the morning, unless you have one of those fancy things. You pop it in and it's got the pods. I still do it the old-fashioned way, so it still takes me 6 minutes. 6 minutes is just not a lot of time. I mean, that's pretty small. So here are a couple cases that I've taken care of where time was just critical. 1.5-year-old child, almost certainly this was non-accidental trauma, presented to an outside hospital almost at 5 o'clock in the evening. They immediately recognized that this was a patient that they could not take care of, so they sent this patient from rural Ohio to where my hospital is in Columbus, Ohio. The time that it took them was 2 hours. In that time, you can see right here, this, you see how it's like, if you just look at this as almost like an art painting, you see how there's this sort of gray here, or this darker here, and there's this whiter here. That is certainly not normal, but it's more normal here than it is right here, where it's almost entirely violated. Okay, it's almost all one color. So this is brain under severe pressure with very little blood and oxygen flowing to it. I did everything I could for the child. We gave drugs to lower the brain pressure. I did what's called a hemicraniectomy, where we take off one side of the skull to give the brain more space. I put in a monitor where I could tell what the brain pressure was. Still wasn't enough. We had elevated intracranial pressures that we couldn't control, and we ultimately lost the child. Another case, so again, injury happened about a little after 7 o'clock, or at least the patient was seen in an outside hospital a little after 7 o'clock. You see this tiny little rim right here? So that's an epidural hematoma, okay? And that is non-surgical, okay? I wouldn't bother taking that to the operating room. By the time the patient made it to my hospital, he was changing. His neurological exam was getting worse and worse and worse. So he said, okay, let's throw him back into the CT scanner, see what's going on. What's changed in this basically 3-hour, 4-hour time period. And what we had was we had sprouted an epidural hematoma right there. And that's not so subtle, okay? You can see that pretty good. And you can see the temporal lobe is now pushing on the brainstem. This is a bad thing. So, again, almost the exact same treatments. We took the patient back. This is what a hemicraniectomy looks like. So this is the temporalis. This is that muscle, like right here, that chewing muscle. We've taken that down. I've taken off this part of the skull. This was not this patient, by the way. This is a very angry brain. That patient did not have quite as angry a brain. But you can see we've made a big hole in that skull. And what we do is we leave that skull off. We leave that skull off. We actually put it in the freezer, and then we come back after the fact, and we repair everything. I can put that skull back on later down the road. But in this case, kid was went to an acute rehab, had some outpatient rehab, and full recovery. So when I'm measuring intracranial pressure, A lot of different ways I can do that. I can stick a lead directly into the brain. I can stick it directly outside of the brain, or I can stick it into the cisterns of fluid called the ventricles, and I can monitor the brain pressures. If I can monitor your brain pressures, I can treat you. When I get a bad brain injury, I put in an ICP monitor, and then you go through a rigorous type of protocol. If your intracranial pressure is elevated, there are a couple of different things that I can do for you. I do very basic things. I can get a head CT, see if things have changed, like they did in that second case. I can give you more sedation. You're probably intubated by this point, so I can start giving you some heavy-duty narcotics or benzos, kind of bring your ICPs down. I can drain a drain that I've put into your head to take off some of that pressure. If that is not enough, I can give you neuromuscular blockade to make your body completely relaxed, and sometimes that'll bring your brain pressure down. I can give you what's called hyperosmolar therapy. Anybody in here ever put salt on a slug as a child? Raise your hands. I mean, we're all sociopaths as kids. Yeah, so you know how it shrinks, right? The sick brain does the same thing. So you put very salty fluid in the brain, and the brain shrinks. It's one of the ways that I can treat your brain for that. I can also give you high potency barbiturates and completely bring your brain metabolism down to almost zero. Please.
How do you, or have you treated glioblastoma brain tumors?
Yes, absolutely. Unfortunately, I have.
And were you able to operate, or?
Yeah, so this is a very different, glioblastoma multiforme is grade 4 glioma. So this is the worst type of a certain type of brain tumor. So what we do for that is similar, but slightly different. We give steroids for that. You wouldn't give steroids for traumatic brain injury. It's actually bad for traumatic brain injury, but you will for tumor. We can cut out as much of that tumor as we can get. We can't get the entire thing, unfortunately, in general in GBM. But you just kind of give it every possible treatment that you can. And, for tumors like that, it is in general, by and large, palliation. You're trying to sort of drag that fight on as long as you can, knowing that it's something you're probably going to lose it. I am so sorry if you or anybody you know has that. It's an awful, awful thing. Please.
The question, I don't know if this needs to be later or not, but I have a veteran that I was with during a neurological examination of an MRI after.
Yeah.
Okay. And I think it was lay terms that the neurologist was giving us, and they said, your frontal lobe looks like scrambled eggs.
That is lay terms, yes, absolutely. I can't even interpret scrambled eggs. I guess what it means is that it would probably frontal contusions. Did a person fall and hit their head?
Actually, there were 3 different head injuries, but one was a car accident.
So this was scrambled eggs long after the fact?
Yes.
So basically what the neurologist was saying was that he could tell that there had been brain injury from before. What happens is, so this will look less gray, and you'll see more dark, okay, which is fluid. And so what happens is, as the brain gets injured, it shrinks, and that's probably what he was talking about. Yeah, that scrambled eggs. So, phase 3.
Just one more question,
Yeah,
along the same lines, kind of. CTE.
A chronic traumatic encephalopathy.
Okay. As a result of TBI.
Correct.
What does that mean to us lay people?
So that used to be called punch drunk or pugilistica, dementia, or there were a couple of different terms for that. But chronic traumatic encephalopathy is basically just type micro injuries, a lot of micro injuries over time, okay? And these are these football players who have been on the front line and just boom, helmet, just day after day in practice, day after day in games. And over time, even if you don't ever have a concussion, and certainly if you do have a concussion, that kind of takes its toll on the brain.
You just took me down the road a little bit.
What's that?
You just took me down the road a little bit in my own mind.
Yeah.
The guy on artillery piece that is firing artillery constantly over and over
Sonic
again.
waves, one after another, after another, after another. Just
Still
kind of like,
applies.
and it's the same way I think of those types of injuries, and we'll get to that in a second.
Okay. Thank you.
No. I'm going to kind of go through some of this nonsense. So those types of injuries, I think of those types of injuries almost as like we used to think about smoking and how we still think about radiation. So where, you know, one cigarette, not so bad for you, don't smoke. Anybody who's ever thought about it? You guys are way outside of the demographic. And if you do smoke, please, dear God, stop. You know, smoking over time, over years and years and years, and that's what really has that dramatic effect. Radiation, a little bit of radiation, not a bad thing, but CT scan after CT scan, you know, that's when it starts to cause tumors in the body and whatnot. How many people have taken care of a patient who was on cognitive rest? Have you guys ever heard of this concept? This is sort of a new concept that we have for traumatic brain injury. It's where we give the brain kind of time to take a break. We haven't defined this very well. We don't really know what it does very well, but we sort of still employ it. It's kind of one of these things, like it's early in the stage of therapy. And what I tend to tell people, I'm kind of a between the goalposts kind of guy. Like, I'm not super loose, but I'm not super tight either. You know what I mean? Like, I sort of, if I'm going to have a therapy, I sort of try and gear it so that people can actually do it. So what I tell people as they're getting back from an injury, start low, go slow. If it feels good, fine. If it gives you a headache, stop doing it. Listen to your body. I tell people 30 minutes of some action and then 30 minutes off. So if you're going to read a book, read the book for 30 minutes and then give your body a break for 30 minutes. If you're going to watch TV for 30 minutes, give your body a break for 30 minutes. The one caveat to that are these immersive video games that a lot of young men play. So Gears of War for 6 hours, not a good idea. And I have actually seen that cause severe bad headaches, and at one time I have seen that cause a seizure in patients who had a traumatic brain injury and then started back in those types of activities and feel too fast. And it's just so immersive. You just get so wrapped up that you don't feel the headache starting, and then you put the controller down and it's like, oh, this is just pounding. In your patients who have had a traumatic brain injury, a lot of things that we look for. Don't be surprised, obviously memory difficulties, that's expected, but don't be surprised about emotional swings. Patients who are tearful and crying and very emotional or very angry and outside of their personality. Don't be surprised if they're having difficulties with concentration, and don't be surprised if they're sleeping. Some of these patients, after fresh out of a traumatic brain injury, can sleep like 20 hours a day, like they did when they were tiny little babies. And they can do that for weeks at a time. And we'll talk about sleep. Day to day, you may see waxing and waning. So patients doing better, doing worse, doing better, doing worse. But week to week, they should be doing better and better and better and better. And if you have a traumatic brain injury patient who is not, certainly if they're not getting any better, or definitely if they're starting to decline, that's the patient that needs to get seen by somebody quickly. Concussions. Mainly this slide is just dedicated to the fact that you do not have to have loss of consciousness. You do not have to have a blackout to have a concussion, okay? All it takes is to be defined as having a concussion is a change in your mentation. So feeling like, oh, bell's spinning, or I'm dizzy, or I feel out of it. That is a concussion. And if it lasts less than 15 minutes, then you're a grade 1. If it lasts longer than 15 minutes, you're a grade 2. And if you have a loss of consciousness, congratulations, you had the worst concussion, but you can definitely have a concussion without loss of consciousness. Okay? So if this happens to your kids, take them out of the game, for God's sake. They're not playing NFL football or baseball or whatever. And they need to protect their brain. These are the types of things that I live for. It's the post-rehabilitation where a patient has gone through the hospital, has gone through rehab, and comes back to see me. So this is a guy who literally was riding his bike on Blood Mountain. I am not making this up. In Georgia, and fell and wrecked and hit his head against a tree. We went down to see him in the emergency room. We immediately took him up to the operating room. We did a surgery as fast as we could. Everybody thought this kid was going to die. Like, there's no question, the kid's not going to make it. But he made it. And then we said, wow, this kid is going to be wrecked after the fact. He really wasn't. And I mean, he's gone on to operate independently in society. He's married, he has a kid. And I mean, these are the, you could see, that's where his trach was. Okay, so, you know, oftentimes you deal with tragedy, but every once in a while, you know, you get that reason to not give up hope. This is going to be the part that of this talk that I think is going to be most topical for you guys. Traumatic brain injury and behavioral health. So this is one of my favorite MC Escher drawings, and it kind of sets out what I'm going to talk about, which is that mental health and traumatic brain injury are intimately entwined. Okay, folks who have mental health problems before the injury are more likely to have a traumatic brain injury, and those traumatic brain injuries can exacerbate, can cause new mental health problems, or can exacerbate existing mental health problems. And this is an unrecognized epidemic in our country, as you will see. You know, I'm from the East Coast and also from the Midwest. Californians, you guys are known for being politically correct. I'm going to say this slightly politically incorrect, but hey, incidence of TBI. Who gets TBI? Boys do, because they're dumber than girls. Children get TBI more than adults, because they do dumb things. So, and the data bear that, you know, not very, very succinctly put thesis, they absolutely back me up. If you look at this, men, way more than women, have traumatic brain injury. Okay, we're doing way dumber things, and we're doing them from 15 to 24. And if you look in your clinics, that's who you're going to see. Okay? As you age, as you mature, as you decide, maybe I shouldn't stand on that banister, you know, you're going to have less traumatic brain injury. So, this vista, Florence, Tuscany. You can see the Arno River. You can see the Duomo. I consider myself a Renaissance man. And I look at this and it just fills me. It fills my heart with joy. Okay? That being said, my heart being filled with joy is supplied by the mechanics that are going on up here. So there is a dichotomy to humanity that we can appreciate these beautiful things, these beautiful pictures of art. But we are doing it with science. Okay? And this is kind of the cast of characters that we're going to talk about very briefly. Prefrontal cortex, this is the part of the brain that does planning. It engages in high-grade activities like, can I make a cake, or can I balance my checkbook? Nucleus accumbens, this is the fun part of the brain. This is the reward center. This is where, you know, we see a Snickers bar, we eat that Snickers bar real quick, and we feel good, briefly. This is the amygdala. This is sort of the emotional center of the brain. When I am being chased by a mountain lion, this is the part that is like, oh boy, this is bad, a mountain lion is chasing me. Okay? Hippocampus. This is the part of the brain that remembers the time I got chased by a mountain lion. Cingulate gyrus kind of is one of those connecting parts, and the fornix right here is another connecting part. The thalamus is the part of the brain that's like the operator. Okay? It's you ever seen those old films where the lady's doing this thing with the wires to connect the people in the hotel, you know, who are calling? That's the thalamus. Okay? And we'll talk about sort of the system that's set up. Hypothalamus, amygdala are sort of our emotional centers of the brain. These are connected to the memory center of the brain, which is the hippocampus. Hippocampus directly connects to hypothalamus and amygdala through fornix. Prefrontal cortex connects to all of this. So our thinking part of the brain connects to our emotional part of the brain through the thalamus. The cingulate gyrus sends messages from the feeling part of our brain back to the memory part of our brain. All of this stuff is interconnected. And if you goof with it, surprisingly, you break it. The strange case of Phineas Gage. Phineas Gage, in 1848, was doing something very dumb. He was building a railroad. He was helping to build a railroad, and he had this stake, and he was packing in powder, and he was looking over his shoulder, talking to people, packing in this powder, and then a spark happened as he's packing in this powder, and the stake that he was using flew 80 feet in the air and managed to pass here, through his eye, out the top of his head. Okay? Amazingly, this man in 1848 survived. Okay? Because, I mean, he could have died from meningitis, he could have died from the injury itself, he didn't have blood transfusions, he was in the boonies, I mean, he was like in New Hampshire. Even if he had been in like Boston, you know, Harvard Medical Center right there, you know, he could have easily have died, but he did not. And he damaged this part of the brain, and that's really what kind of was the impetus for neuroscientists to start to think we are the meat inside of our heads, because he was emotionally changed after the injury. Now, you can kind of, as we look back and look at the sort of the historical account of Phineas Gage, you can see that he probably didn't have the dramatic change in his personality that people have attributed to him, but he definitely had sort of a post-traumatic brain injury course where he had a lot of the types of symptoms that we see in our traumatic brain injury patients now. As far as mood disorder after traumatic brain injury, it was recognized as early as the early 20th century, and unfortunately we still haven't caught up, okay? So we knew that this thing was going on, but we're still not very good at recognizing it. Major depression happens 40% of the time, okay? That's a huge burden, okay? Anxiety happens about 40% of the time. Again, a huge burden for these traumatic brain injury patients. And despite this, we still don't recognize this enough or treat it enough. This is the data that I was telling you about. So, 340 VA patients. When they looked at them, they did a Venn diagram looking at post-concussive symptoms, PTSD, and chronic pain.
What year is this?
What year was this? This was a couple years ago, like 2012, I think.
Is this based off the current guys and were
No.
younger
This,
generation or
you're talking about DSM.
no. For the patients that were being studied, was that based off the veterans now in the current OIF? Or was
Not sure about that. Not entirely certain about that. This was one of the earlier studies looking at this population. Of the 340 patients that they looked at, only 12 patients fell outside of having one of these three diagnoses. That's huge. And a lot of these patients had all of these diagnoses: chronic pain, post-concussive syndrome, and PTSD. So this is a huge burden of mental health problems for these patients who have had a battle-related traumatic brain injury. PTSD. What part of the noodles basically causes PTSD? So, when you have a very scary situation, an IED just went off and the truck in front of me exploded, or my truck exploded and I've been thrown to the ground, the amygdala, that emotional part of the brain, is really ramped up, okay? It is projecting to the hypothalamus. The hypothalamus is causing your sympathetic nervous system to really squeeze out a lot of adrenaline. I mean, you are in the height of battle, and you are just fighting to stay alive. This is just, I almost think of it as like burning a hole in your brain, where it is just creating a memory that you cannot forget. On top of that, if that's not bad enough, damage to this frontal lobe. The frontal lobe is sort of what calms you down. So, mountain lion attacks you, you escape the mountain lion by swimming across a stream. You're sitting on the other side of the stream around a campfire, relating to all of your buddies about how you escaped this mountain lion. The frontal lobe is what's saying, okay, this mountain lion's not going to get you, okay? You're sitting around a campfire and now you're safe. If you damage this frontal lobe, in addition to all the other parts of your brain that you damaged, you have basically put your foot on the accelerator and you've taken the brake away, okay? And that's what, that is, in essence, a lot of the problems that we'll have with PTSD, is that you have multifactorial injuries to the brain that may or may not be recognized, but that's the type of setup that they're causing. Okay? So PTSD, it is a mental health diagnosis, but it is a real brain injury in and of itself. Depression following traumatic brain injury. Dorsolateral prefrontal cortex and prefrontal cortex, these are the parts of the brain that sort of allow us to have activation. They allow us to wake up in the morning and say, it's 8 o'clock, let's eat breakfast, on with the day, okay? And you can have these depressive patients who maybe don't even, maybe they feel depressed, maybe they don't, but they are just sunken and low, and they're hypoactive. And a lot of that is from problems with prefrontal cortex. Some of that is from problems with the reward circuit, nucleus accumbens, okay? So prefrontal cortex, more of an activation type problem. Nucleus accumbens is sort of the anhedonia, the loss of pleasure in life that we get when we're depressed. And if you give me a symptom, I can give you where the problem may lie. Depressed mood, prefrontal cortex. You don't have that activation. Anhedonia, you're not getting pleasure out of the things in life you normally would. Nucleus accumbens, amygdala. So nucleus accumbens, the reward center, amygdala, so that emotional part of the brain. Significant appetite changes, hypothalamus, that's kind of the regulator of, when am I sleepy, when am I awake. Changes in sleep, prefrontal cortex, hypothalamus. Psychomotor retardation, so that's where you're just kind of almost feels like you're moving through water, prefrontal cortex. Fatigue, loss of energy, prefrontal cortex, hypothalamus. And you can go through all of this, but literally what it is that you have these mental health symptoms, but they have a real world place in the brain. There can be actual injuries to the brain that are causing these.
What about with
Please.
suicidality? I noticed that was blamed.
Yes,
Oh.
so that's kind of multifactorial. And that kind of segues into this slide. So again, mental health problems and traumatic brain injury. If you look at suicidality following traumatic brain injury, and this is a huge problem. If you have a traumatic brain injury patient, you need to be asking the typical questions, and really, you guys need to be telling me, my people, this. Have you thought about hurting yourself or others? And that kind of sometimes can strike you down the road of, okay, maybe this patient has something that is outside of my skill set, for me anyway, and I send them to somebody who's a mental health expert. If you look at traumatic brain injury patients and you look at their pre-injury life, 12% will report an attempt of suicide prior to the traumatic brain injury versus the regular population, which is 9.2. It's a significant increase. Okay? Ideation for suicidality is highest in their 2nd month after injury and their 8th month after injury, which just kind of means that as you see these patients, pardon me, delicious lunch by the way, you have to be thinking, are you having suicidal ideation? Are you making attempts at suicide? 25%, that's a huge number. 1/4 of these patients are having suicidal ideation. I mean, that's a huge number. And if you look at multivariate analysis for predictors, initial depression prior to injury, no-brainer. Pre-injury history of some sort of psychological diagnosis, again, that pretty makes sense. Prior suicide attempt, less than a high school education or having Medicaid. Again, it's just stressors in life, basically, that cause these patients to have these feelings. Sleep disturbances following traumatic brain injury is something to look for. Some of these people are going to have hypersomnia. Some of that can be due to problems with the hypothalamus itself. So decreases in the types of neurons, these orexin-positive neurons that cause us to fall asleep. Or I'm sorry, orexin-positive neurons cause us to actually be awake. So if you have decreases in these, you can have hypersomnia. You can sleep, like I said, up to 20 hours a day. Maintenance insomnia is a very common complaint among these traumatic brain injury patients. I actually experience this occasionally. Like if I'm going to do a big surgery a couple days down the road and I'm kind of ramped up about it, I'll wake up at like 4 o'clock in the morning, a couple hours before I would normally do that. That's what maintenance insomnia is, where you're not able to maintain your sleep. You can fall asleep, you just can't stay asleep. And this can happen, months after the injury. So again, for these traumatic brain injury patients, we need to be asking them about sleep and trying to treat their sleep disturbances. Sleep is extremely important for patients who've had traumatic brain injury. By allowing the brain to relax, we can increase the energy to the brain. We can allow for neurorehabilitation and neuroplasticity, where parts of the brain that were not injured can take over for parts of the brain that were injured. And sort of, if you look at the molecular biology of these things, there is a new concept called the glymphatic theory of sleep. And this is basically that the glia, those support cells that are surrounding your neurons, when you're sleeping, are actually actively taking away waste. Okay? So we already knew that sleep was important, but we're starting to figure out on a molecular level why is sleep important. And that is it. This is one of my favorite photos. This is a patient I took care of, and I still take care of, who had a very bad tumor. After surgery, after chemo, after radiation, giving me high fives. Any questions for me?
What are some of the usual components of brain surgery? I get that you're dealing with swelling for the hematomas. You're also fixing. What are you stitching fractures, or what else do you do when you perform the brain surgery?
So, sort of from a top down, you're taking care of any scalp lacerations that may have happened. And you repair those. You are taking care of any skull fractures that may have happened. So if the skull is depressed into the brain, you can elevate that out. And we'll actually use titanium screws and little plates to kind of keep the skull in place as it heals. If there is a tear in the dura, which is that leathery covering of the brain, we'll stitch that up. The amazing thing about brain surgery is that it's less about the brain, more about protecting the brain, including protecting the brain from the surgeon. So really, when you're doing brain surgery, you're trying to leave as low a footprint as possible. You're really trying to be a good custodian of the brain. When, anytime we're doing brain surgery where we have to go into the brain, the two things that I'm thinking about as a brain surgeon, how can I get in there and change the patient as little as possible? And is there a way that I can get in there without just plowing through cortex? So I'll go through natural cleavage points in the brain.
You talked earlier with regard to PTSD about the cortisol and burning a hole in the brain. Do we see similar effects in the brain for children who have experienced abuse?
Yeah, let me rephrase what I said. It's not really burning a hole. It's almost like burning an image in the brain that you just can't get past.
The visual.
Yeah, or just, even vision itself. When you look at a cake, you're doing more than looking at the cake. Your brain is taking in everything, and it's taking in that image, it's taking in that smell, it's taking in, your thoughts of like, oh, I loved cooking with mom, and mom has maybe passed, and I'm having this emotional recurrence. And this is all going on in the back, mind you. Okay, so you think you're just looking at the cake, and you're not looking at the cake. Like, it is a flood of multimodality that's all coming into your brain. Cake is nice, but imagine that as being like a traumatic experience. And now we've turned that completely on its head. The parts of the brain that have burned that image are hippocampus, hypothalamus, and amygdala. So the reward center, the emotional center, the center that controls how we feel, and the memory center. Okay, so they burn that image into the brain. What we've cut off sometimes with PTSD is prefrontal cortex, so we can't tell the brain to just calm down. Okay, and that's what kind of ramps that up. You mentioned cortisol. That is anybody's guess as to, that is a huge, so cortisol is like steroids, basically. And that's actually one of the things that I'm working on is we know that steroids are bad for traumatic brain injury. They were good for that tumor. Sort of the effects that it has is complex and not very well.
So there's not enough research to support the child getting back to the brain.
Oh no, anytime you're talking about kids, you can almost guarantee there's not as much research as there is in the universe, unfortunately. What we tend to do for children is we take the research that's done in adults and then we have like maybe a 5 to 10 year lag, and then we recapitulate. That's oftentimes, unfortunately, the case. Yeah.
Can TBI cause ADHD?
Can TBI cause ADHD? I mean, my answer to that is yes, because I think TBI can cause any set of symptoms that you can think of, because it can change the brain. But again, I would go back to that, that picture that I had of the two arms drawing each other. The children with ADHD are going to be more likely to have the TBI. So you may have a child who is undiagnosed, has an injury, and then that pushes them over the edge so that their behavior is changed enough where you're actually making the diagnosis, if that makes sense. So I think it's pretty rare that you have the normal child that has the brain injury and then goes on to be diagnosed with ADHD, and the brain injury is the causative agent of the ADHD. But it certainly, is it possible? Absolutely. Please.
So do you see this grouping like amygdala, all these pieces of the brain together, working together? Do you see there being a problem with seeing that as somewhat reductionist in the concept of consciousness?
Sure. Yes, 100%. You can't take your eyes off the prize. I think the question that you're asking is, can you break this down into tiny pieces and do you lose sight of the bigger picture? Yes, I 100% agree with you. But
What do you mean by that?
the best way for me to describe that is the parts of this thing are not equal to its whole, okay? In the same way that if I took a frog and I cut it into 4 pieces, I no longer have a frog, right? I have 4 pieces of a frog, or 5 pieces of a frog, and they're not equal to the frog itself. The concept of the brain is not, you can't, I don't think that you can reduce it to, this is taking place in the amygdala, this is taking place in the hippocampus. It's way more complex than that. And this is a fight that is going to go on. And if you want to take an even further leap philosophically, I don't think we're actually going to be able to discover what makes the brain work, and the reason why, and this is kind of mind-blowing to me anyway, it like really keeps me up at night, is that we're studying the human brain with the human brain, and you can't actually, you can't make the human brain work efficiently enough to actually figure out the human brain. So I oftentimes, this is gonna make you think like maybe I need to stay here for a little while. But I actually think what would happen if an alien race came down that had much more complex CNS efficiency and a much more highly complex CNS? Would they be able to figure out our brain in the same way that we can take like C. elegans and figure out every cell in C. elegans and figure out their entire neural processing? But yes, to answer your question, and I probably haven't answered it that well, but you can't break it down to the sum of its parts. Like it's way more complex than that. But you can't just say, okay, your brain is a bunch of tofu and there you are. That doesn't work. If that makes sense.
The topic of consciousness itself.
Yes.
Kind of where it comes, the rubber meets the road.
Yeah. But consciousness itself, I can disrupt consciousness in so many different places by just taking out, a piece of the thalamus. I can take out part of the brainstem. I can take part of the hypothalamus. And that completely disrupts it. So it exists in many different parts of the brain working all together.
How much information were we able to gather after Iraq?
Oh, from the vets? We're still gathering it because unfortunately we're still in Iraq and Afghanistan.
Right. We've had guys back now for a good 10 years, so I don't know what
Huge amount. And it's not even so much that we're gathering information, because it's not like, suddenly we had traumatic brain injuries. Okay? We've had traumatic brain injuries for years and years and years, but now you have a situation that's set up where we are responsible for it, and, you've got all these vets coming over, and you got to do something with them. And You know, I think what it's highlighted is how little we knew about it before this. And it's caused us to really ramp these things up. But the wars that we've been fighting have, you know, unfortunately brought us a lot of patients, have exposed our dearth of understanding, and have allowed us to make headway. Please.
I'd like to comment on that, if I may. We've known about TBI and PTSD since prior to World War I.
Right.
We actually were diagnosing differences on the paperwork after World War I. One was, if you had it one way, you're a sissy, and the other way, you got blown up. The scenario that's going on today, that we're addressing the TBI victims from the war, is kind of sad, because these guys are coming back with lots of different problems that they're using test questions from 100 years ago.
Yeah.
And I'm getting guys that used to be a manager someplace, and they're coming back with a head injury, and they can't even pass the entrance exam to get their old job back. But they can pass that test, and the question's written 100 years ago.
Mm-hmm. Yeah, it doesn't set up, and we talked about this before at lunch, it doesn't, if you have a patient who you suspect has subtle injury, one of the best things that you can do is send them for neuropsych testing. You may not be able to improve their life, but you can certainly highlight deficits that they may have following the injury, and then that may allow them to compensate for those deficits, either permanently or until the brain has neuroplasticity that can allow them to move past that injury. Please.
What's the difference between a functional MRI and like the SPECT technology?
They're very similar. So SPECT, thallium, those types of scans, you're looking for uptake. With the functional MRI, you're actually asking patients to engage in certain tasks so that you can map out where the function is taking place.
Is it more just like a snapshot still, and the SPECT is like a 15-minute movie, right? Or like a 3D image?
You can get 3D imaging from both.
Okay.
Okay. With the functional MRI, essentially what you're doing is you're using some modality to map out where the patient is having an increase in metabolism after you cause them to do some function.
Right.
Okay, so move your thumb, that highlights primary motor cortex and supplementary motor cortex, and all of the pathways that lead down from the brain to actually moving the thumb. Please.
I have a quick question. I think I just missed this part. On one of the questions it asked about elevated brain pressure and if they're inversely correlated with heart rate and blood pressure. I completely don't even remember you saying anything about it.
Could you repeat that again?
I can just read your question.
Yeah, read
sure,
your question.
Okay. So in patients with elevated brain pressure, the vital signs tend to reflect tachycardia, rapid heart rate, and hypertension level pressure. True or false?
So it would be, I may not have mentioned that. So what you see in patients that have elevated intracranial pressures is you'll actually see bradycardia, right before they have brain herniation. So their heart rate will go low, 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 and their blood pressure will go way up. So you see hypertension and bradycardia rather than
So that'd be false, right?
What's that?
That'd be false.
That'd be false.
Yeah.
Yes, the answer is false, guys.
A pragmatist, a woman of my own.
So one last request.
Please.
Is there any way you can put your presentation here on YouTube for the world?
It'll be
Or
on
the
top
whole
of the
world.
Veterans don't
He wants the
know.
whole world.
I get a new guy coming home from the war, he don't know any of this.
Sure.
And I guarantee you the guys from Vietnam, World War II, they don't know any of it either.
Yeah.
I mean, great.
Yeah, thank you very much. Please.
Just a quick question. I heard that there could be brain damage from if you're firing the gun, like in Afghanistan, you're firing it during.
So firing a gun probably is not going to cause, like the big gun, if you're having a lot, if you're hearing a lot, or you're having a lot of impact from, those types of events, and certainly blast injuries themselves, will cause, basically just rattling. And then damage inside the brain through a mechanism similar to like a diffuse axonal. But not from firing.
Dr. Eric, thank you very much for coming today. I'd like to ask you a question, please, on hereditary, on brain aneurysm. Because you do a lot, seem to be the most well-spoken brain surgeon I've met yet.
Oh, that's very sweet.
At least can answer a question, because my neighbor's a brain surgeon, and he says we make a difference. I want to know, with a brain aneurysm, how and why?
How what?
How and I want to just ask.
How and why?
I mean, how can this happen? I'm listening to all your trauma here. Not somebody who's had trauma, very young age, and just get a headache and boom, drop.
Yeah.
And you get a call from someone like you.
Yeah.
And get here as quickly as you can. And there's nothing.
So what the question was, what sort of how and why do we get
How does that
brain
occur? I mean, at a young age, I always thought a massive brain aneurysm, and then it becomes like 60 or 70, somebody has a stroke or something. Not at 43. That's the question I'm trying to ask.
Yeah. So you can actually, we have them in pediatric patients. Occasionally we'll get brain aneurysm. So the how of a brain aneurysm, if you imagine like a river that forks into two different rivers, or any bending point in that river, as the water goes through, or in this case as the blood goes through vessels, it can cause shearing forces on that vessel wall. And what will happen is that vessel wall will break down over time, and then you'll get an outpouching of that vessel wall, okay? So you had some mild injury that over time causes an outpouching, and then blood starts swirling into that outpouching, right? And then the outpouching gets bigger and bigger and bigger, and as the outpouching gets bigger, the vessel wall that is around that outpouching actually gets thinner and thinner and thinner, almost like you're blowing up a balloon, and then at some point, and then it is just, all hell breaks loose. You get a very bad subarachnoid hemorrhage, and that is, it's a very bad injury. Aneurysmal subarachnoid hemorrhage is very bad when those happen. So if you can discover an aneurysm before the fact, it's always a good thing so that you can sort of treat it if it needs to be treated.
Thank you very much. I appreciate that.
Yeah, absolutely. Any other questions for me? Thank you guys for your